Hi, this is Pete Georgakakis, ER doctor at the University of Iowa, an EMS physician in this area as well. So today we're going to do something a little different. We're going to talk about one of the big groundbreaking trials of 2018 that came out actually when I was in my EMS fellowship, and it's called the PARAMEDIC-2 trial. So it's technically called a randomized trial of epinephrine in an out-of-hospital cardiac arrest. It was in the New England Journal of Medicine, published August 23rd of 2018 by Perkins et al. So I just wanted to kind of go through this because this is one of the biggest studies that has been done recently in cardiac arrest care. And I've also heard it being used a lot in maybe out of context in the wrong way. And so I just wanted to kind of break it down because it's something that as EMS providers, students, physicians, you will be hearing more and more from. So this is a study that came out of the United Kingdom. So it was a randomized double-blind trial of 8,014 patients with out-of-hospital cardiac arrest. The medics that were part of the study were from 5 different ambulance services. And so essentially it was testing the treatment of IV epinephrine versus giving IV saline. And so again, this was double blind. So the paramedics providing care in the out-of-hospital cardiac arrest did not know what they were giving because the vials looked the same of epinephrine and saline. And then afterwards in the evaluation, obviously the patient didn't know, but then in the evaluation afterwards, they did not know either when they were evaluating the statistical significance of various outcomes, what patients had received what. And so their primary outcome was survival at 30 days. Now, this has been done before in a lot of studies because the ultimate test of success is, are you dead or not? However, something that's been coming up more and more, and we'll talk about this later, because in the study they talk about this, what makes this so groundbreaking is that it was now talking about not just survival, but survival to discharge out of the hospital with a good neurologic outcome. And so they use the modified Rankin score. And basically that's a score from 0 to 6, 0 being you have 0 symptoms, everything's fine, you're normal like me or you. And 6th is death. So the higher the score, the worse off you are. And so they considered a good neurologic outcome to be a modified Rankin score of 3 or less. So you'll have some disability, you might need some assistance with ADLs, but overall you're relatively independent and you're alive. And so we will break this down further, but just kind of the spoiler alert, they found the patients that received IV epinephrine during out-of-hospital cardiac arrest, and there were 4,000 of them, they had higher incidence of return of spontaneous circulation, ROSC. And so they found at 30 days, 3.2% in the epinephrine group survived versus 2.4% in the placebo group. And this was statistically significant. And so this study has been touted as this is why epinephrine is so important in out-of-hospital cardiac arrest. However, I would argue, and my colleagues would agree as we've talked about this for years now, what I would argue is one of the more important points that this study raises that requires more research is there was no significant difference in the patients in the epinephrine group or in the placebo group that got saline during out-of-hospital cardiac arrest that survived to discharge with a good neurologic outcome. 2.2% of the epinephrine group and 1.9% in the control group. So while you might get a pulse back more often with epinephrine, because as we know, you give enough epinephrine, you can get the ambulance cot to have a pulse. There is no difference between either treatment, which is to say no treatment with epinephrine or giving epinephrine, in who will leave the hospital with good neurologic outcome. Furthermore, what this study found is at discharge, there was more severe neurologic impairment. So remember, the Rankin score of 6 means you're dead. They found more patients with a score of 4 or 5 in the epinephrine group versus the placebo group. So let's kind of dive into this a little more. So why do we use epinephrine in cardiac arrest? Well, it's a sympathetic agonist, and so you get a strong alpha receptor constriction, which increases your vascular tone, increases your aortic diastolic pressure, which increases coronary flow. So the thought is you're getting more flow to your heart during cardiac arrest, which increases your thought of getting return of spontaneous circulation. Stimulating as well the beta receptors can cause the downside of increasing your oxygen demand and workload on a heart that's already very taxed. So there's always been this question of the theoretical risk is concerning, but there's also this theoretical benefit of why we give epinephrine. There's been animal studies in the past that show, again, increased ROSC, return of spontaneous circulation, but we've never evaluated, but these patients that have a pulse, are they truly having a meaningful life? How, we as human beings define that, which is not living on a ventilator, not living in a hospital, with no cognition, no relationship, but truly being out and about. And so in the past, we've talked about different administrations of epinephrine. If you go back to the cardiac arrest updates lecture, there's quite a bit of the literature review regarding epinephrine over the years. But we've decided, do we give epinephrine or not? Early on, they decided yes. So then it was, do we give more epinephrine? Is more better? Versus does the frequency we give it matter? And we've talked about that in the past. So that is not what this study is about. That said, there have been studies that compare 1 milligram versus 5 to 10, or epinephrine plus a pressor versus a placebo, and there's no evidence of better outcomes in epinephrine, but it does increase ROSC. So studies of more than 500,000 patients have reported higher rates of ROSC, but poor neurologic outcomes when you got epinephrine. That said, those studies always had a lot of confounders, so a lot of other things that were probably muddying the waters, that we could not say that the epinephrine caused the poor neurologic outcome. So this study came out of the fact that the people that did the study wanted to talk to the public and say, okay, we've talked about ROSC, we've proven that this medicine can increase your rate of getting a pulse back, but what is meaningful existence for you? And so they used a committee that was not just medical providers, it was also members of the community to say, in your mind, what is a meaningful survival outcome that you care about? Is it just pulse or not? Is it good neurologic outcome? Is it just getting out of the hospital? How do you define it? And so ultimately they decided the thing that they cared about most was good neurologic discharge with good neurologic outcome. So this committee called for a study that was placebo controlled, so that you'd have a treatment and then a group that did not receive the treatment, to see if epinephrine was safe and effective in cardiac arrest. So that is, keep in mind what this study is looking for is it safe and effective in cardiac arrest? And they define that as survival at 30 days. So this was multi-centered. Like I said, there were multiple hospitals. There were 5 ambulance agencies. It was placebo-controlled, double-blinded. And so the inclusion criteria were all adult patients with out-of-hospital cardiac arrest that were treated by the paramedics that were part of this trial. And you were excluded if you were known or apparently pregnant, less than 16 years old. Your cardiac arrest was thought to be due from asthma or anaphylaxis, or you had been given epinephrine before one of the paramedics from this trial showed up. And then one of the 5 ambulance services excluded any cardiac arrest related to trauma. So essentially how you were put into this trial, if you met these criteria, if you were found to be in cardiac arrest, CPR and defibrillation had happened, and it was unsuccessful initially, that you were moving down that ACLS algorithm and it was time to give epi, you were randomly assigned to either the epinephrine group or the saline group. And again, no one knew what you were getting because of the packaging, the delivery all looked the same. And then you gave these doses repeatedly every 3 to 5 minutes, just like you would in ACLS. Now that said, a patient that was in the epinephrine group would continually get the epinephrine. They weren't every time being randomly assigned back and forth to epinephrine or placebo. Once you were in one of the groups, that was it. And then your treatment continued until you either got a pulse, resuscitation was stopped, or you were handed over to the hospital. Once you were in the hospital, they administered care as they normally would, and the trial kind of protocol stopped. So that said, that's one of the confounders here, is that patients going to different hospitals may have gotten different care because it was not protocolized, other than just they followed national guidelines, including different temperature management, hemodynamic ventilation criteria, that kind of thing. So the primary outcome that they are looking at here is survival at 30 days. Secondary outcomes were survival to discharge, length of stay in the hospital and ICU, survival at discharge and at 3 months, and then neurologic outcome at discharge and 3 months. And the good neurologic outcome, as we said, was that Rankin score of at least less than 3. So they did a bunch of complicated statistics, and they calculated how many patients do we need to determine we have the right number to estimate survival. Again, that is what they were looking for, was survival. And they were basing it on kind of the international and national data in out-of-hospital cardiac arrest survival. That's about 7% is who survived cardiac arrest. So they did what's called an intention to treat analysis. So they included a patient that if they had been randomized to one of the two groups, they included them regardless of if they finished the treatment. So if they had been put into the epinephrine group, started to get it, they were kept in there regardless of if they continued to get epinephrine. And then they were able to adjust for certain factors like age, gender, the interval between 911 call and ambulance arrival, which is very important because, as we know, in the first 3 minutes of a VFib arrest, you have an 80% survival, but every minute after decreases survival by 10%. So that interval is important. The interval between getting there and getting the drug, and then the cause of the arrest, the initial rhythm, if it was witnessed or not, and if bystanders did CPR. So ultimately, they screened about 10,600 patients, ultimately used 8,000 assigned to one of the two groups. So 4,015 were in the epinephrine group, 3,999 in the control group. They were basically matched so that the two groups were as similar as they could be in their age, gender. Most were male in both groups. Shockable rhythms was about 20% in both groups. Over 90% were thought to have medical causes of the arrest, and then 37% were witnessed, and about 60% had bystander CPR. That said, the interval between the call going out to arrival was about 6.6 minutes, and the arrival to drug given was about 14 minutes. Both are pretty big intervals, and I think that potentially, for those of you, depending on where you practice, can have huge impacts on the care being administered. So the epinephrine group had a higher interval, 36.3%, and 11.7% in the control group. So more were transported to the hospital in the epinephrine group. And so again, going back to the big point this study was looking for was survival at 30 days. And so they found that 3.2% of the epinephrine group survived at 30 days, and 2.4% survived in the control group, and this was statistically significant. So the number needed to treat with epinephrine to prevent one death at 30 days was 112. So you need to give 112 people epinephrine to get someone to survive at 30 days. And so this was statistically significant. Again, them defining survival as a heartbeat at 30 days, having no mention of their neurologic outcome yet. So now, those who, when we get to the other outcomes, there really was no statistical difference in length of stay in the hospital, in the ICU, the number that were admitted, the age, witnessed or not, bystander CPR or not, initial rhythm, response time, drug administration, any of those things. There was no statistical evidence that these things modified the effect. But the other two things that are most important here is there was no significant difference in patients who were discharged with good neurologic outcome. So you may get a pulse more with epi, but again, you are not more likely to leave the hospital with a good neurologic outcome. Furthermore, 31% of the epinephrine patients had poor neurologic outcome versus 17%. And this was statistically significant. So epi gets you a pulse more, but this study suggests gets you poor neurologic outcome. And so I'll stop here and say where I've seen it up to here is I've seen one of two things happen if this is as far as you think. You either hear, great, epinephrine works, keep doing it, it's getting our patients back, it's getting ROSC, let's take it every time. Or you're hearing that last part of the worst neurologic outcome and hearing, this is why epi is terrible, we shouldn't be giving epi to anyone, it's making people brain dead. Neither is what this study was designed to do. This study tells you you are more likely to have a heartbeat in 30 days. We already knew that. We knew that epinephrine can increase ROSC rates. What we need to start using the information in this study to do is to decide if we collectively as a society, globally, have decided survival is better defined as good neurologic outcome, we need to be studying that. What medicines, what interventions, what things can we do that increase discharge and survival to good neurologic outcome? And so we have found here, when you look at the other parts of the chain of survival, so like when we talked about the number needed to treat, the number of people that need a certain intervention for someone to survive. In this study, the number needed to treat with epi to prevent one death was 112. We have found the number needed to treat with early recognition. When you think of that chain of survival, when you first have to practice your AHA, card carrying classes, when it says go activate the emergency response system. So early recognition has a number needed to treat of 11. So you need to activate EMS 11 times to save a life. Bystander CPR, you need to, the number needed to treat of bystander CPR to spare one death is 15. So 15 bystanders need to do CPR to save somebody. And then defibrillation, the number of times you need to defibrillate, the number of patients that would require defibrillation to save one is 5. So here, compared to the 112 that would need epinephrine to survive, you're seeing that these other simple interventions that we have in the chain of survival are much more important and much more likely to have an impact. That said, we cannot say again that epinephrine is the cause of the poor neurologic outcome. So we cannot walk out with this study and say this is causing brain death, because it's really hard to know why these outcomes were worse. Again, we saw a very large delay, 16 minutes in some cases, of getting meds on board, up to 7 minutes of getting to the patient when they've been in cardiac arrest, and only a small proportion of them got bystander CPR. So there are multiple things before EMS even got there that could have affected the neurologic outcome. And we have not done enough to know yet what is causing all of this. We don't know if the brain was affected by the ischemia or reperfusion injury afterward. That said, of those where resuscitation was successful, most needed they needed a continuation of life-sustaining or ICU care. And within there, about 33% had withdrawal of care, another 33% die. And so some of the big limitations here, there were no variation in dosing intervals or dosing doses. And so, this was done in the United Kingdom, where protocols could be a little different. We don't know if we had given epinephrine faster, if it hadn't taken an average of 16 minutes to get drugs in, would this have changed things? We also don't know the baseline neurologic status of a lot of these patients. If a lot of these patients already had pretty severe disease, we only know at the end what they look like. We don't know enough information before we got them what they would have been like. So they also found that they did a lot of their calculations assuming there was a 7% survival rate to determine how many patients they would need to do their power analysis. And they actually, in their incidence here, they only found they had less survival than they predicted. They predicted 7% survival, and there was only about 3%, which can start to mess with your results a little bit. So the other thing, they didn't really monitor if the protocols were adhered to by the trial paramedics. So they wrote it on paper, they trained the paramedics in how to do it, but there was no real accountability to make sure this was being done correctly. And so again, I hate to keep, reiterating this, but I just want to make sure that the results of the study, the significance you understand, but you also aren't misunderstanding what you can take away from this. So you give epinephrine to out of hospital cardiac arrest, you will more likely have ROSC compared to giving nothing. But this study also shows that in this group with this protocol and in these timeframes, this did not change discharge with good neurologic outcome, and the epinephrine group had possibly worse neurologic outcome. Now, The other things here was this study was not powered for the neurologic outcome element. This is just an outcome they found. It was powered specifically to just survival at 30 days. You would have to do a little bit of a different study in terms of numbers and a different analysis to determine the neurologic outcome portion. The other thing is we can't generalize to the in-hospital setting. So this really cannot be, so let's just take epinephrine out of all of our drug kits, because being dispatched from a station to a house 9 minutes away is very different from being kind of in a center pod or a nurse's station and a patient arrests down the hall and you're there in 30 seconds. That could completely change things. And here we really don't get to see what the effect of time to drug administration does. So I think the other thing to really take away from this is to truly understand how we're defining survival. And as you're working and determining your own practice, if you're in charge of protocols, if you're teaching this, I think it's really important that you understand how we as a society determine survival. As you're talking to family, as you're seeing in your ERs, a patient getting ROSC after cardiac arrest, if they've been down for an hour, understanding that getting ROSC does not mean that the job is done or that this patient has been successfully resuscitated. It means they have a pulse. So anyway, PARAMEDIC-2 trial, check it out. It's a groundbreaking study, super important for what we do. And yeah, take care. We'll talk to you soon.